Okay, I'm back. Adult respiratory distress syndrome is where we're at now. And glasses on, glasses off, can't decide. All right, in adult respiratory distress syndrome, there is a sudden progressive form of acute respiratory failure. So clearly, if you got ARDS, you got respiratory failure. And what you need to, this definition of ARDS is it in a nutshell. So if you can understand this definition, then ARDS will make sense. It produces a non-cardiogenic pulmonary edema. So let's think about that. Normally, if someone has pulmonary edema, it's because they have a fluid volume excess, right? As would occur in congestive heart failure, especially, acute decompensated heart failure. That would produce pulmonary edema. Well, in ARDS, the heart's not the problem. In ARDS, you have pulmonary edema because there is a disruption in the alveolar capillary membrane. Namely, there's an immune inflammatory response that causes the pores, for lack of a better word, the things that stuff is supposed to cross over that allow for diffusion to happen. The alveolar capillary membrane is semi-permeable. That's a great word. It is. It is a semi-permeable membrane that allows some things to cross through it. Well, in this ARDS, that semi-permeable membrane becomes excessively permeable to stuff it shouldn't. And so it allows for stuff to flood the alveolus, to move from the capillary space into the alveolar space. All right, that's the non-cardiogenic pulmonary edema part. You end up with diffuse infiltrates because of all this stuff that's flooding into the alveolar air sacs, airways, and all that. The membrane itself becomes thickened and fibrotic, resulting in loss of compliance. And when you have loss of compliance, you have a severe restrictive lung disease. I know Jeff talked about restrictive lung disease. So you got stiff lungs. And then the other part of this definition is refractory hypoxemia. Refractory means that not responding to maximum therapy and intervention. Okay, that's what refractory means. And then so bad that it does result in tissue hypoxia. So in a nutshell, your definition of ARDS, non-cardiogenic pulmonary edema with diffuse infiltrates, progressive loss of compliance, refractory hypoxemia, and tissue hypoxia. And we'll start taking some of that apart. Now, the alveolar capillary membrane becomes damaged, and it becomes more permeable to the intravascular fluids. So the alveoli fill with fluids, you get severe dyspnea, you get hypoxemia, the lungs become stiff, you get all these infiltrates. About 150,000 cases a year, and by itself has a 50% mortality rate. If you combine it with gram-negative sepsis, then the mortality goes to 90%. Gram-negative sepsis that produces septic shock and ARDS will kill most people. If you look at the stages of edema in the ARDS, letter A here shows you a normal alveolus and a pulmonary capillary. And then in B, you've got interstitial edema. You've got edema refers to water, right? Okay, you got water in this interstitial space. And you can kind of call that interstitial space a second space. So it would be like having puffy hands and feet, okay? And then you'd have to consider the alveolus to be a third space, okay? Because clearly you're not supposed to have fluid there. And then you can see that as interstitial edema forms, then you get flooding of stuff into the alveolus, crossing that blood-gas barrier. Now, it wouldn't be so bad if it was just water, but it's not just water. ARDS develops from a variety of either direct or indirect lung injuries. It's never a primary disease. It always occurs secondary to some other insult to the body. How do you like that? The exact cause for the damage to the alveolar capillary membrane is not known. The pathophysiologic changes of ARDS are thought to be due to stimulation of the inflammatory and the immune system. The immune system, for some reason, interacts inappropriately or abnormally with the lung tissue, especially that alveolar capillary membrane. And that inappropriate action of the immune system allows that capillary membrane to become very permeable, the alveolar membrane to become very permeable, and stuff that's not supposed to flood the interstitial spaces and the alveolar spaces do so. Some indirect lung injuries. Sepsis, the most common cause, especially gram-negative sepsis. Massive trauma is another pretty common cause. SIRS, the systemic inflammatory response syndrome, is associated with ARDS, as is multi-organ dysfunction syndrome. Some other things, acute pancreatitis, we talked about that in third semester, and some patients will develop ARDS from that. Multiple blood transfusions can cause ARDS. There's some trigger that triggers the immune system, and the immune system then causes the lungs to interact inappropriately. Heroin overdoses has been known to do it. Shock states, and sometimes patients on cardiopulmonary bypass. I haven't seen too much of that, but it is possible. In patients who have multiple risk factors, they're 3 to 4 times more likely to develop the ARDS. Now, direct lung injury, things like aspiration, inhalation injury, as in a burn, pneumonia. Your aspiration and your pneumonia are particularly common. The others certainly can cause it. Oxygen toxicity, radiation pneumonitis, and near drowning can produce ARDS. Wow. The pathophysiology of ARDS, well, you have an injury to the alveolar capillary membrane. A couple things going on. You've got release of inflammatory mediators that increase the permeability of the alveolar capillary unit. You've got vascular narrowing and obstruction. If you increase the permeability of this capillary membrane, you get outward migration of blood cells and fluid from the capillaries, causing pulmonary edema. So the inflammatory mediators increase permeability, causing lung edema. The vascular narrowing and destruction, okay, produces pulmonary hypertension, the pulmonary edema, the narrowing obstruction, the bronchoconstriction. This is all due to release of inflammatory mediators. Bronchoconstriction, permeability, vascular narrowing and obstruction produce impaired gas exchange. I'm going to sneeze, excuse me. Goodness gracious. Then on this side, we have damage of your type 2 cells. Type 2 cells produce surfactant, so the surfactant gets washed out. Surfactant helps stabilize the cell membrane and allows it to have compliance and recoil. You end up with atelectasis. You get a hyaline membrane that forms. I got a picture of that coming. Those things decrease lung compliance, further impairing gas exchange.